Welcome students, I am Dr. Ramakrishna Chaitanya, your anesthesia faculty. So welcome to this session of anesthesia high yield images. I know you guys might be stressing out too much about these images and a lot of things are running in your mind. So I can really imagine what is running in your brain right now when we are talking about these image based sessions. So on a lighter note, let us start with a meme of the image. So this is the current situation of the students. This is the current situation of the aspirants who are preparing for the entrance examination. Right. So on a lighter note, I begin with it. So most of the students are very much crazy about these image based sessions. Yes, there should be some point for this craziness, right? So the reason is, the image based sessions are very important. It acts like a very quick revision of the subject. I can understand this point, but at the same time, don't neglect the fact that without watching some content, somewhere or other, if you are only looking at these images, you might get a lot of confusion over there. So my sincere request to these students is, watch the images. It acts like a very good revision source. Utilize these images in a proper way, then it will be very fruitful for you. So without wasting much time, shall we start seeing the images? What are their important images in anesthesia? So what I did is, I kept the images in a defined fashion so that I can tell you in a sequential fashion. I am not putting it randomly. One image from regional anesthesia, one image from airway equipment. So I made headings so that you will understand what are the images where we are seeing and how to correlate the things. Okay, so we'll start the discussion of these images. Right. So anesthesia itself, it starts with ABC. Right, we are all the basic stuff people, right? So we are not high end people like medicine and surgery. So anesthesia, the basic stuff, A, B, C. A with airway, right? B for breathing and C for coffee. Okay, leave about that breathing and coffee. So we'll start with the airway equipments, right? So what are the airway equipments? What is this equipment? Where it is used? Now see this equipment. This is very commonly used equipment in my day-to-day practice. This is called as anatomical face mask. Anatomical face mask. What is the purpose of this anatomical face mask? Is it is used to provide pre-oxygenation. It will be providing pre-oxygenation. How much amount of pre-oxygenation you should give, but how much, for how much period of time? So generally pre-oxygenation means providing 100% of oxygen. For how much? That means how much percentage we are giving? 100% of oxygen. For how many minutes? For 3 minutes. What is the advantage I am getting with this pre-oxygenation is my apnea time is increased. So the apnea time is going to increase by 10 minutes. Right? So this is the advantage of pre-oxygenation. So for all elective surgeries, you should be doing pre-oxygenation with 100% oxygen for 3 minutes. Right? Sir, what about emergency? So in emergency, you can do pre-oxygenation with 100% oxygen. Don't reduce the oxygen. With 100% oxygen for 8 vital capacity breaths. 8 vital capacity breaths. Okay, so this is vital capacity, right? That's a maximum inspiration, maximum expiration. So in 1 minute, if I do this in 1 minute, again the same time, apnea time can be increased. So time is not available. Then least preferred is, least one is 4 vital capacity breaths in 30 seconds. Because, I am giving muscle relaxants, you will be in apnea. So within 3 minutes, normal apnea time for you and me right now with this 21% of oxygen is 2 to 3 minutes. So 2 to 3 minutes is very, very minimal amount of time. If I want to buy some time, I have to give the pre-oxygenation for the patient, right? So this is a classic image which can be asked in your entrance examination. Now, what is the modification? This modification, I think you might have seen during your internship. So this modification is also an anatomical face mask, but it is used in children. Used in children. What is the name of this mask? This is called as Rendell-Baker mask. Same, the purpose is same. Just because children, you cannot use that adult size, we use the other size, that is called as Rendell-Baker mask. Okay, now you will connect this tube circuit from here and we will give the oxygen to the patients. Okay, so the first equipment is pre-oxygenation, right? The second one, what is this maneuver? This is very commonly asked in the last 4 years of NEET-PG entrance examination. 2 times this question has been asked. What is this? So what are we doing this? I am putting the head like this. So this is called head tilt. And what I am doing for this chin lift. At the same time, I am pulling the jaw forward. Pulling the jaw forward. This is called jaw thrust. Jaw thrust. So head tilt, chin lift, jaw thrust. This is called triple maneuver. Triple maneuver. Where do we do this triple maneuver? While giving pre-oxygenation for the patient, you have to hold the mask in such a way that there is a head tilt, chin lift, jaw thrust, and give pre-oxygenation. Not only that, even for your bag mask ventilation also, you have to extend this procedure. You have to do this. So you should be learning this technique of triple maneuver. Head tilt, chin lift, jaw thrust. Okay, I don't know which one they have asked in your examination, but this is a very important image. So I am particularly showing this image so that you can get benefited from this. Right? Then coming to this, what is this equipment? So this you might be knowing, this is called as Goodell's Airway. What is the purpose of Goodell's Airway? The purpose of Goodell's Airway is it prevents tongue falling back. Prevents tongue falling back. Because the one of the dangerous complication that will occur when you become unconscious is your own tongue. I tell in my offline classes, one of the dangerous organ in your body is your tongue. Why? Because when you are awake, you will talk unnecessarily with your tongue and land up in problems. But when you become unconscious, your own tongue will fall backwards and it will cause airway obstruction. So to prevent this, we use this equipment that is called Goodell's Airway. Right? The advantage is it's a very simple device. You can put it in your pocket, you can carry to your home, you can take it to your home, you can steal it from the hospital. Whatever you want to do, you can do it. But what is the disadvantage is it will stimulate the gag reflex. No one will ask you the advantage. Right? So the disadvantage is it can cause gag reflex. So it requires some sedation to produce this, to insert this Goodell's Airway. Right? Now what I am doing in this second image, I am checking the correct size of Goodell's image. Checking the correct size. Why I have to check the correct size? Because obviously, if the size is too small, you will swallow it. Right? Swallowing means again this big problem. If I use a large size, it will traumatize my airway. So I have to choose the correct size. How I am checking? So see this. If this is the Goodell's Airway, I am putting it from the angle of the mouth to the tragus, or from the angle of the mouth to the angle of mandible. So both the ways you can check and you can insert it properly and you can prevent the tongue falling back. Right. Now, what is this equipment? This was asked in the recent NEET-PG 2024 examination. What is this? Some students, they got confused as uncuffed endotracheal tube. No. This is a nasopharyngeal airway. Nasopharyngeal airway. Right, sir? How to differentiate from uncuffed tube? Uncuffed tubes are very small. They are very, this much thick amount size will not be available. Right? So this, can you see there is a flange like structure. Whereas uncuffed endotracheal tube, here I'll show you that image also, don't worry. You have a plastic connector. You have some plastic connector like this. Right? So this is a key differentiating point from a nasopharyngeal airway to an uncuffed endotracheal tube. So what is the purpose of nasopharyngeal airway? Not only tongue fallbacks when you become unconscious, your pharyngeal walls also will collapse. This nasopharyngeal airway prevents collapse of the pharynx. Collapse of the pharynx. That's the beauty of this nasopharyngeal airway. So what I am doing this here, obviously I am checking the correct size. Why I need to check the correct size? Check the correct size. Again, same reason. If it is a smaller size, it will be stuck up into your nasal cavity. Then it will create lot of mess. Right? Larger size will damage your nasal mucosa. It will cause bleeding. Right? A very important question. How I am checking this is I am putting this nasopharyngeal airway from the alley of the nose. Can you see here? Lateral edge of the nostril, alley of the nose to the tragus. So this is how I am checking it. Now, what is the contraindications for insertion of nasopharyngeal airway? This is a very favorite question for the examiners. The first contraindication is adenoid hypertrophy. Children with large adenoids, obviously you will not pass this nasopharyngeal airway. Second one, fracture base of skull. Sir, how to identify fracture base of skull? It is very simple. By looking at the patient, you can come to a diagnosis that is called as raccoon's eye. Raccoon, not some other name, right? Raccoon. Coon means it is a panda, right? So the third contraindication is coagulopathy. In these three conditions, we will avoid inserting the nasopharyngeal airway, right? So they are available in three sizes: 6.5 to 8.5. Okay, 6.5, 7.5, 7, 7.5, 8.5 sizes they are available. So you can use some from 6.5 to 8.5, it is available, right? So this is nasopharyngeal airway, right? Now what is this one? This is called laryngoscope. Everyone knows it. Laryngoscope, right? And this everyone knows it. This is called Macintosh laryngoscope blade, and this is Miller laryngoscope blade. Macintosh, the name itself, you can see the image, it is curved. So this is a curved blade and this is a straight blade. Curved blade is generally used in adults, whereas straight blade is used in children. Right now, one or two important points about this laryngoscope. You have to insert the curved blade. You have to hold the laryngoscopy blade in the left hand, insert it from the right corner of the mouth, push the tongue to one side, go deep inside, visualize the epiglottis, and lift the hand away from the patient's body. Do not bend at the wrist joint. Most of the beginners, they do this mistake. So Macintosh blade is inserted from the right corner of the mouth, and you can push the tongue to one side. That's the reason why it is curved, so that you can push the tongue to one side and go deep inside, visualize the epiglottis and lift the hand. Whereas Miller blade, you have to insert it from the center of the oral cavity, because in children the tongue size is larger, so you cannot push it. So you have to insert it from the center of the oral cavity, depress the tongue. You should not push it. Depress the tongue, visualize the epiglottis, include epiglottis, and lift the hand in the same fashion. So this is very, very important equipment that is called laryngoscope, which has got curved blade and straight blade. Curved blade is used in adults, straight blade is used in children. Right? The next image, a very important image. After doing laryngoscopy, how do you visualize this glottic opening? There is one system of classification that is called Cormack-Lahan scoring system. What is this Cormack-Lahan scoring system? Why I have kept this image means, in the recent NEET-PG 2024, in one of the question of ENT, they mentioned this scoring system. It's not the correct answer. They mentioned it. Cormack-Lahan scoring system. So what is this means? After doing the laryngoscopy, the glottic opening is assessed by this scoring system. So it has got four systems: Cormack-Lahan 1, 2, 3, 4. In 1, you can see the entire vocal cord opening. In grade 2, you can see the posterior apertures only. In grade 3, you can see the epiglottis. In grade 4, you can't even visualize the epiglottis. Right? So this is the Cormack-Lahan scoring system. Might be some examiner might be interested, because there is one more scoring system which I will show you, that is called Mallampatti scoring system. Right. So Cormack-Lahan scoring is done after doing the laryngoscopy, to visualize or to categorize the glottic opening, how much you are seeing. So that is called as Cormack-Lahan scoring system. Right. So once I see this vocal cords, I will pass the endotracheal tube. What is this? This is called cuffed endotracheal tube. Everyone knows it. Which substance it is made up of? It is made up of polyvinyl chloride. So polyvinyl chloride made cuffed endotracheal tube. Now cuffs are of two types. So this one is specifically low pressure, high volume cuff. Low pressure, high volume cuff. So this is commonly used in our hospital. Why? Because it is low pressure. What will happen if I use high pressure means it will damage my tracheal mucosa. Now, what is this portion? This is called pilot balloon. What is the purpose of this pilot balloon? You will push the air so that the cuff inflates. What is the purpose of the cuff? The purpose of the cuff is to prevent aspiration. Prevent aspiration. Right. You might have seen there are some numbers are there. What is the purpose of the numbers? It will act like a guide. How much depth I am inserting. Right. And this black mark indicates the depth to which it should be passed. It should be passed. Right. Now, can you see here? The bevel is curved bevel. Right, and there is one more opening here this side. When I took the picture, you can see here there is one more opening. So there are two openings at the distal end. Two openings at distal end. Why there are two openings means if this main lumen is also blocked, it can ventilate through this alternate lumen, and this alternate lumen here it will be there, and this alternate lumen name is called Murphy's eye. Murphy's eye. Okay, so this is cuffed endotracheal tube. Generally, we use cuffed endotracheal tube in adults. Okay, right. What is this equipment? What is this equipment? This is called uncuffed endotracheal tube. Uncuffed endotracheal tube. Where it is used? It is used in children. Why it is used in children? If I cut the larynx of an adult vertically into two pieces, this is the longitudinal section of your larynx. Can you see these are the vocal cords? This is the glottic opening. This is the supraglottic region. This is the subglottic region. So which is the narrowest portion in an adult larynx is this glottic region. If I cut the same larynx of the child and see vertically, if I cut it, now can you appreciate which is the narrowest portion in a children glottis? The narrowest portion is subglottic region. Can you appreciate it? That is the reason why we are using uncuffed endotracheal tubes in children. So what is the recent recommendation? Can you see here? Both are cuffed endotracheal tubes only. But what is the difference between these two? This cuff is called micro cuffed endotracheal tube. Micro cuffed endotracheal tube. As per recent recommendations given by the society people, it has been said that instead of uncuffed endotracheal tubes, we prefer micro cuffed endotracheal tubes. Unfortunately, this is available in our country also. So it might be a question for the examiner. This has not asked till now, but they can ask you this question. Right? So can you see here? This is a normal cuff. This is a normal cuff. When you compare to normal cuff, then the micro cuff is smaller and distally located. Distally located. You cannot, when you are seeing these image-based sessions, don't concentrate on the color of these images because color is something, which can be changed. So concentrate on the content. The content is this cuff is slightly distally located so that you can easily identify it. There is no other way. If I show you normal cuff and when you compare it with a micro cuff, then only you can come to a conclusion. If I show you normal micro cuff and say what is this, you cannot tell. But most of the examiners, they don't give alone micro cuff. They might give you some other options if at all they want to ask. So the better way is to choose a micro cuffed endotracheal tube. This is most recent recommendation. Recent recommendation in children. In children. Right? So this is micro cuffed endotracheal tube. What is this? I said you this one is low pressure, high volume cuff. This one. Right? Now I will show you the high pressure, low volume cuff. Low volume cuff. When we were doing post graduation in 2007, we were using these endotracheal tubes only. So this is made up of red rubber. This is called as red rubber endotracheal tube. Red rubber is made up of, it's called as red rubber because the shape is like, the color is more like a orange color, not exactly red. It is made up of lead like substance, but of late we are not using it because the cuff is high pressure, low volume. What will happen if I use a high pressure cuffs means high pressure cuff can cause damage to the tracheal mucosa. Damage to tracheal mucosa. So prolonged intubation will lead to tracheal mucosa. So how much high pressure will cause damage if it is greater than 25 centimeters of water? So that's the reason why of late we are not using it. This high pressure, low volume covered endotracheal tubes. Okay, right. What is this endotracheal tube? Can you see here? This endotracheal tube is so flexible that if you see carefully, the inside of the endotracheal tube is lined by a spring-like structure. We call it as flexible or flexometallic endotracheal tube. Normal endotracheal tube, if I put it like a knot, what is happening? It is getting kinked. The gases will not flow through this kink. But this flexometallic tube has got a beautiful advantage that even if you bend it also, the gases will flow comfortably. So there are so many names. This is called as flexometallic or armored endotracheal tube or wire reinforced endotracheal tube. Where it is used. Now see here, suppose if the patient position during the surgical position is prone position. If I use a normal endotracheal tube, it will bend like this and the gases outflow will be obstructed. So this is generally used in prone position surgeries. Prone position surgeries and head and neck surgeries. Any head and neck surgeries, we can use this flexometallic endotracheal tube. Right. Then what is this endotracheal tube? They are already having this curvature and this is called as preformed or prefixed endotracheal tube. We call it as RAE. Already curve is there. So preformed curvature is there. So the name is called Ring Alder Elwin endotracheal tube. Don't worry about that name. So just remember RAE. So this portion will go into my oral cavity. This portion is coming down. It is looking down. Right. So this portion will be coming like this. So this is called south pole or south facing. As it is facing downwards, we called it as south facing. And this is called north face RAE tube. North face RAE tube. Where we use this RAE endotracheal tube is generally for any lip surgeries, upper lip or lower lip surgeries, most commonly cleft lip surgeries. Okay, this is where we use this RAE endotracheal tube. Again, this has not been asked in your entrance examination, but I wanted to show in this image based section. Right. Then comes this equipment. What is this equipment? This is called as double lumen. Can you see here? There are two lumens are there. This is one lumen. This is two lumen. So this is called double lumen endotracheal tube. What is the purpose of double lumen? Double lumen is there. So the purpose is this is used in lung surgeries, right? So this is used in lung surgeries because in lung surgery, suppose if the surgeon is doing surgery on the right side, you should be able to separate this. There should not be ventilation, right? So you should ventilate only on the left side. So for this reason, we use this double lumen endotracheal tube, right? Where you have two cuffs at a very distant place. So this cuff is a tracheal cuff and this is called bronchial cuff. Bronchial cuff. So if you inflate the bronchial cuff, the airflow to that area, that lung will be reduced. Generally, we use it for lung surgeries like pneumonectomies, lobectomies, etc. Okay, so this is wonderful. That is used in lung surgeries, double lumen endotracheal tube. Right. Sir, here also two cuffs are there. What is this endotracheal tube? Now, these two cuffs are there, but can you see here? These two cuffs are very closely placed. This is called laser endotracheal tube or Malindrot endotracheal tube. Right. Now, can you appreciate the difference between double lumen endotracheal tube where the cuffs are very, very far away, whereas here, can you see here, the cuffs are very close together. So what we use is, because in one of the cuff, what we will do is we will put normal saline. In another cuff, we will put a dye. We'll put a dye. So during the laser procedure, laser means it is cutting. So during the laser procedure, if one of the cuff is accidentally punctured, then what will happen? The dye containing that cuff, it will leak, and it will give that stain on the airway during the surgical procedure, and surgeon can be cautioned, right? Or sometimes this endotracheal tube is wrapped. Silicone endotracheal tube is wrapped with aluminum foil. Aluminum is resistant. Normal endotracheal tubes, what will happen, when we expose to laser, they will get broken. If it gets damaged during intubation or ventilation, you cannot pass the gases, right? So silicone endotracheal tube wrapped with aluminum protects the endotracheal tube from laser burns or damage. Because the moment the endotracheal tube is damaged, your endotracheal tube contains oxygen. Laser is a high power energy, oxygen energy. There can be airway accidents also. So laser endotracheal tube or laser shielded endotracheal tube can be identified by having two cuffs, or sometimes it will be wrapped up with a aluminum foil. Okay, right. Now what is this one? This is called flexible fiber optic bronchoscope. What is the purpose of flexible fiber optic bronchoscope? Means it is the confirmation for me, the gold standard method to know the exact location of the endotracheal tube. So in lung surgeries, when I pass that endotracheal tube, I should know where the endotracheal tube is. It should not come in between the surgical procedure. So we will use this flexible fiber optic bronchoscope. So please concentrate. You might be getting confused with colonoscope and endoscope, but compared to colonoscope and endoscope, my flexible fiber optic bronchoscope is very, very thin. It's flexible, right? So that's very, very important. Colonoscope and endoscope, they are larger in sizes. My endo flexible fiber optic bronchoscope is very, very thin and it's malleable, right? Okay, right. Then coming to the next one, this is called video laryngoscopes. These were very popular in anesthetic armamentarium because during COVID period, if you are intubating normally, seeing like this, lot of aerosols are coming and infecting the healthcare worker. So we started using video laryngoscopes like laparoscopic surgeon. So we are putting the endotracheal tube, we are visualizing the endotracheal vocal cords, and we are passing it by looking into the TV. So how can you identify video laryngoscopes? You have this display. So that display will guide you that whether this is a video laryngoscope or not. So it's better. In difficult intubation also you can consider this video laryngoscope. Right. Next laryngoscope which I wanted to show you. This is called TrueScope. TrueScope. Just see the name. Right, TrueScope has got two different curvatures that will be useful in case of difficult intubation, and you have got some oxygen provision option also. From here oxygen can be provided. Just see the image. This is called TrueScope. Because why I wanted you to see these images which were not asked in the examination means these are all the images that are there in the textbook. Maybe some examiner is interested to ask you these questions. That's the reason why I want you to see this, right? And this one is called air track scope. So we can see that there can be provision for attachment of the camera, and you can pass it the endotracheal tube, that is called channeled. It will be channeled from this portion, so that once you are near the epiglottis, you can just pass the endotracheal tube comfortably, right? And this one is called Bullard's laryngoscope. Bullard's laryngoscope. In difficult intubation situations, these equipments will be very handy in our practice. Bullard's laryngoscope. Okay, right. What is this one? This is known as supraglottic airway device. Supraglottic airway device. This is called as classic LMA. Classic LMA. LMA means laryngeal mask airway. It was introduced in 1980s by Dr. Archie Bain. So how to insert this laryngeal mask airway means take the LMA, any form of LMA, hold it like a pen and insert it along the hard palate until you meet the resistance. Once you are getting the resistance, just take out your hand, inflate the cuff. The cuff will get sealed. Right now, the advantage of classic LMA is easy to insert. But what is the disadvantage? It is supraglottic. Why it is supraglottic means it is sitting above the glottic region. So this portion, the tip of the LMA is above esophageal sphincter. Esophageal sphincter. Upper esophageal sphincter. When you insert it properly, the tip is above the upper esophageal sphincter. These two portions, the lateral walls are at pyriform fossa. Pyriform fossa, and this portion is present at the base of the tongue. The base of the tongue. Right? So this is called supraglottics. So if it is supraglottic, something is aspirating, it will contaminate your lungs. So cannot prevent aspiration. Cannot prevent aspiration. So it is less useful in case of pregnancy, prone position, or laparoscopic surgeries or emergency surgeries. You cannot consider this LMA because it will not prevent from aspiration. Right? Then what is this equipment? This is called ProSeal LMA. This was asked as an image based MCQ in your entrance examination. ProSeal. It is called second generation LMA. Why it is called second generation LMA? Can you see here? There is a drain tube. What is the advantage of this drain tube is if something material is aspirated, you can connect it to a suction and you can suck it out. So any LMA which has got a drain tube, we consider it as a second generation LMA. So we modified the LMA by adding a drain tube and made it as a ProSeal LMA. Right. Now what is this? From the LMA, we are passing the endotracheal tube. That means it is called intubating LMA. Intubating LMA is a first generation LMA. Why first generation LMA? Because there is no drain tube. The only advantage is you can pass the endotracheal tube. Right now they don't have this. Inside there will be small bar like structure that is not available with this intubating LMA. Now very important image with LMA Supreme. LMA Supreme, you can identify it is made up of polyvinyl chloride and it is a second generation LMA. Sorry, ProSeal is also second generation LMA. LMA Supreme is also second generation LMA. How to differentiate between ProSeal and second generation LMA Supreme means, can you appreciate here? LMA Supreme has got a prefixed curvature. So easy to insert. Easy to insert. This is the drain tube. This is the drain tube. So it is made up of polyvinyl chloride and it has got a prefixed curvature. So you can easily insert this LMA, right? LMA Supreme, right? The next image, this is called as LMA Unique. Why it is called unique? Because normal LMA is made up of latex, right? You might have seen this, this material is latex. This material is again latex. This is made up of latex, but some people are prone for this allergy. So we made it with polyvinyl chloride and we called it as LMA Unique. Okay, this is called LMA Unique. I will write it here. Right, then can you see this LMA? The LMA is made up of latex only, but this is flexible. Right, this is called flexible LMA. Flexible LMA. Now this image I am expecting in your entrance examination. This is called eye gel because this is commonly used by lot of anesthetists in the country. Eye gel. This is second generation LMA. Sir, this is also straight. But what is the difference between ProSeal and second generation LMA? Here there is no pilot balloon. Sir, if there is no pilot balloon, I can see the drain tube. This is the drain tube. I understood it. I can connect the suction. I can aspirate the material. Then how are we inflating? No need of inflation. No pilot balloon. This silicone gel takes the shape of your oral cavity and it will snugly fit into your oral cavity. So that's the beauty of the eye gel. That's the reason why most of the anesthetists, they want to use this eye gel. And here, can you see here, there is a bite block because this, when I insert this eye gel, it will be at the incisor point. So it should not bite it. So we have some thick structure that is called as bite block. Bite block. So from this you can supply the oxygen, you can connect the drain tube and suck out the aspirated material. In between, to prevent the biting from the injury, we have a bite block and it has got a silicone gel. Right now, long back when we were doing the post graduation before the LMA insertion, this is the king. What is this? This is called esophageal combi tube. Esophageal combi tube. Sir, this is also having two cuffs. Sir, so many two cuffs are seen. How to differentiate between this esophageal combi tube? Okay, I'll write it here so that you will understand. This is called esophageal combi tube. No, the only point, it has also got two cuffs. It is also distantly placed. But can you appreciate here? There are some holes are there. So before the LMA insertion, most of the paramedics, they used to use this esophageal combi tube. You take the tube, pass it blindly into your oral cavity. One of the tube will go, mostly it will go into esophagus. So once it goes into esophagus, you inflate this cuff and you will start ventilating. So from here, the gases will go into your lungs. So the in between these two cuffs, if there are holes, then it will become esophageal combi tube. But in between these two cuffs, no holes. That means it is double lumen tube. I have written it as DLT. If the two cuffs are closer together, it will become laser endotracheal tube, malindratic endotracheal tube. Okay. Right. So what is this one? This you might have seen in your casualty. So this is called as a stillet. What is the purpose of the stillet? Because sometimes you can see the glottic opening, but you cannot negotiate the endotracheal tube. So in those situations, in order to bend the endotracheal tube, we will put a stillet. Can you see here how I am putting the stillet? So it is very commonly used. So please have a look in your casualty. This is available, stillet, right? And this one is called as bougie. I will write the name here, stillet. And this one, which is long one, what it is the purpose? This is called as gum elastic bougie. Gum elastic bougie means after doing normal laryngoscope, you take that bougie and you will insert it. Once this, because this is very long thin substance, you can easily pass the bougie. Once the bougie is inserted, you can pass the endotracheal tube through this bougie, right? So this is called gum elastic bougie. Okay, I'll write it here, gum elastic bougie. Right. What is this image? This is called what we commonly use. Suppose while doing laryngoscopy, if teeth gets injured, or if I want to insert a throat pack, we use this. This is called as Magill's forceps. Magill's forceps, and this is your stillet. Right. This is called. These are the various gadgets what we use during our intubation. Right. Now, what is this procedure we are doing? Can you see here? We are passing a guide wire from this portion and it is coming out through the nose. Right. So, we are passing through here and coming out through the nose. Once this guide wire is coming out, we are passing the endotracheal tube and this is called as retrograde intubation. This is called retrograde intubation. I wanted you to see this because of late in your entrance examination, so many questions on airway management are asking. So that's the reason why, suppose if the mouth opening of the patient is restricted, I cannot open the mouth due to some cancer in my oral cavity. Now what I will do is I will make a hole I'll make a hole in the front of the neck and I will pass the guide wire from the trachea and it will generally come out through the nose. Once it is coming out through the nose, I will again hold that guide wire and I will pass the endotracheal tube from the top. So by this we can secure the airway of the patient. Generally it is done. This procedure is done. Retrograde intubation is done if the mouth opening is restricted. If the mouth opening is restricted, then we do this. Right? What is this procedure? Here, can you see here? I am applying the pressure on the cricoid cartilage. So this is your thyroid cartilage. Below the thyroid cartilage, we have cricoid cartilage. So if I am applying the pressure on the cricoid cartilage, this maneuver is called as Sellick's maneuver. And when do we do this Sellick's maneuver? We do it in case of emergency. What is the other name for emergency? It is called rapid sequence intubation. I have written RSI. Rapid sequence intubation. I need to secure the airway of the patient because there is a high chance of aspiration of the gastric contents. So I will manually occlude the esophageal lumen. So this maneuver is called Sellick's maneuver. Right. What is this procedure? So again, this is called superior laryngeal nerve block. superior laryngeal nerve block. Suppose if I don't want to, mouth opening is restricted, I don't want to pass through this retrograde intubation, I can block the nerves and I can pass the endotracheal tube also. What are the nerves I am blocking in this? This is called awake intubation. In awake intubation, I am blocking the nerves. What nerves I am blocking? The first nerve I am blocking is superior laryngeal nerve, and this one is glossopharyngeal nerve. Glossopharyngeal nerve is very present close to the tonsillar fossa, right? And this is transtracheal injection. Transtracheal injection, so that whatever the recurrent laryngeal nerve that is supplied, that will be blocked. Transtracheal injection of local anesthetic. So you can block the nerves and you can gently pass the endotracheal tube through the nose or mouth and you can intubate the patient. Right. What is this one? This might be asked in your examination, where I am stabilizing. Here, this is called Selix maneuver. Selix maneuver. And this, where I am stabilizing the neck, this is called as manual inline stabilization. And when do I want to stabilize your neck? Whenever there is a case of road traffic accident. The first priority in any road traffic accident is to protect the cervical spine. So I can protect the cervical spine by holding the neck like this. This is called as manual inline stabilization. Okay. So what is this procedure? This is called as emergency cricothyrotomy. Just see that, because some examiners, cricothyrotomy, this is my last ditch effort to save the life of the patient. So I'll write it here so that it will not come in between. Emergency cricothyrotomy. Cricothyrotomy. Otomy means making hole. In between cricoid and thyroid cartilage, I am making the hole so that I can secure the airway of the patient. This is done in an emergency posture. This is called as phona. Phona means front of neck axis. Front of neck axis. Right. And what is this tube? This is called tracheostomy tube. Don't say endotracheal tube. I will die. Why? Because the endotracheal tube is very, very lengthy. This is very small. So you have to insert it from the trachea. So tracheostomy. So generally tracheostomy is the domain of the ENT people. So this is called tracheostomy tube. Okay. Right. So identify this position. So what is this position? This position is used in intubation. During the intubation, what we are doing is we are keeping a pillow. We are keeping a pillow behind the occiput, and this position is called sniffing of morning air position. This position was given in recent NEET-PG 2024. Sniffing of morning air position. If you keep the pillow, most of the students, they think the position for intubation is rose position. No. In rose position, we will keep the pillow in between your scapula blades. In between your scapula blades. So if I keep a pillow behind your occiput, this is called sniffing of morning air, and this position we generally do it at the time of intubation. Okay, generally we do it. This is called intubation position or sniffing of morning air. We got some fancy names like drinking of pint beer. You might have seen in many movies, a hero will pick up the bottle and starts drinking of pint beer. Or he might be, there is one position that is called barking dog position. So what is the main important point in this position is there is flexion at lower cervical spine, extension at atlanto-occipital joint. You have to remember this position. Where is flexion? Where is extension? Okay, right. Now, next position. What is this position? Right, this position is called ramp position. What do you mean by ramp? Can you see here? The patient is like a ramp. If you draw an imaginary line from the tragus, it should be passing through your angle of sternum. So generally this position, we will try to keep it in obese patients, because obese patient, they are known to have difficult intubation. So what we will do is we'll put the patient in a ramp like fashion. So ramp like fashion, if I put it, so it will be easy for me to intubate. Okay, so these are the various airway equipments what we use in my day-to-day practice. Now, what are the some images? Let us see some images in airway assessment. So, what am I assessing here? I am assessing the mouth opening by finger breadth technique. Finger breadth technique. I have not used the fingers because I wanted to show you the mouth opening restricted. So if you measure this, we don't measure with a scale. So what we do is we ask the patient to keep the fingers in between his incisors vertically like this. If you are a tobacco chewer, so you might have seen this ad in your movies. My name is Mukesh. Right? Have you seen this ad? Yes. In that ad, you have seen I have eaten tobacco only for 2 years. Now I am like this. Right? Now, how to assess the mouth opening is we'll ask the patient to keep his own fingers. Don't keep your fingers. You keep the fingers in between the incisors. Normal finger mouth opening is assessed by finger breadth technique, and in the normal value is greater than 3 fingers. So you should be able to pass 3 fingers in between your incisors. Now don't become too intelligent and put 5 fingers or 5 fingers are going horizontally. No, it should be placed vertically in between these two incisors. Okay, right. So what is this one? This is called Mallam Patti grading. Mallam Patti scoring or Mallam Patti grading. This is used to assess the difficulty intubation. Now, don't get confused with Cormac-Lahan. Cormac-Lahan is done after doing laryngoscopy, whereas Mallampatti is in the pre-operative assessment. So, in Mallampatti grade 1, can you see uvula is hanging freely? Uvula is hanging freely. So, what we do is, why this is very important. Mallampatti is an Indian. His name is Dr. Mallampatti Sheshagiri Rao. Right, in 1983 he moved to US. Before intubation he asked the patients to open the mouth as widely as possible, and he made his own system of classification. So in Mallampatti grading we'll ask the patient to open the mouth as widely as possible and see the structures that are visible. So grade 1 uvula is hanging freely. In grade 2 the tip of uvula is not seen. In grade 3 half of uvula is not seen. Grade 4, this was not introduced by Mallampatti. It was introduced by Sampson and Young. What they said is only hard palate seen. Only hard palate seen. So this is Mallampatti grading. Right. What is this? Normal cervical spine mobility. So what I am doing is I am drawing an imaginary line from my upper incisors and drawing one more imaginary line after extending the neck. So what is the normal range? The normal cervical range should be 12 to 35 degrees. Right. Now what is this test I am doing here? Who is this gentleman? My image only. Right. So what I am doing here is I am measuring the thyromental distance. The thyromental distance should be greater than 6.5 centimeters. This distance should be greater than 6.5 centimeters. Now, if I pull this down, it will become sternomental distance. Sternomental distance. It should be greater than 13 centimeters. So extend the neck, measure the distance from the angle of the sternum to this mentum, and it should be greater than 13 centimeters. Okay, right. So these are the airway assessment and airway equipment gadgets, images. Right. Now let us see some of the gadgets in the monitoring. So what I am monitoring here, if you see this kind of monitoring where we have placed some leads on the forehead, this is called as bispectral index, where we are analyzing the EEG waveform. Analyzing EEG waveforms. What is the advantage is we can know the depth of anesthesia. Whether the patient can recollect during the procedure or not, we can understand by looking at this monitor. What is the normal value? The normal value should be between 40 to 60. 40 to 60. Right? Now, what is this equipment? This is called triple lumen central venous catheter, CV catheter. Right. So one of the lumen you can use it for measuring the pressure. One lumen you can use it for giving the fluids. The second lumen you can use it for sending the inotropes or any cardiac medication. So triple lumen central venous catheter. And this one, which is yellow in color, this of late we are not using it. I just wanted you to see this image. This is called as pulmonary artery catheter. Pulmonary artery catheter. Now, why I combine these two means triple lumen central venous catheter is inserted in the internal jugular vein and it will monitor the functioning of the right side of the heart. Whereas pulmonary artery catheter, it will be inserted from the internal jugular vein, but it goes up to the pulmonary capillaries and it will monitor the left side functioning of the heart. So how to differentiate? Pulmonary artery catheter is very, very long, whereas triple lumen is very small. Okay, so pulmonary artery catheter, it has got so many ports, minimum 1, 2, 3, 4, 5 ports are there. Okay, whereas triple lumen, maximum 3 ports only. There is single lumen and double lumen. So just see this image. Till now, they have not asked in your entrance examination. What they have asked in your entrance examination is, what is this monitor? This is called this is called neuromuscular monitoring. Neuromuscular monitoring. So what we are doing in this neuromuscular monitoring is we are applying the supramaximal current on the nerve and we are assessing the movement. So what is the most commonly monitored method? That is called train of 4 ratio. So what is happening in train of 4 ratio? You can see here I am giving 4 supramaximal stimulus and assessing the force of contraction. So this is seen in NDMR block. In NDMR block you can see a gradual reduction of the amplitude of contraction and I am taking the ratio of 4th to 1 and we are giving this. So this gradual reduction is called as fade. Whereas in DMR, the amplitude response is diminished, but it is constant. Right? So what is the advantage of train of 4 reaction is you can easily differentiate between NDMR blockade and DMR blockade. So one more important thing is you can see here, this is also NDMR blockade. Right? So this is the beauty of this monitor. This is called as neuromuscular monitoring. The same image was asked in 2020 NEET-PG. Okay, that's the reason why I kept this image. Okay, right. Next one. Let us see and understand some of the capnographic waveforms. So what is this capnographic waveform? So this is obviously the normal capnographic waveform. So this portion of the normal capnographic waveform represents the gases coming from the dead space. This portion is the expiratory upstroke. And this portion is plateau phase and this is inspiratory downstroke. Right? Now this is normal capnographic waveform. Right? What is this? Can you see here? This is looking like shark. Right? My shark is very bad, but okay, this is looking like a shark fin pattern. What do you mean by shark fin? Shark fin means exaggerated phase 3. This is phase 1, phase 2, phase 3. The plateau phase, which should be a slight upstroking, is there. It has been increased. This is called as exaggerated phase 3 or shark fin pattern seen in bronchospasm. Bronchospasm. I will remove this one. I am only not liking my shark. So this is called shark fin pattern. Bronchospasm or partially obstructed endotracheal tube. Partially obstructed endotracheal tube. Right? Can you see here? What is this one? You can see this oscillations. This is called as cardiogenic oscillations. This is normally seen in children. Normally seen in children. Okay. Right. Then what is this one? This one is called Curer cleft. All these images they have asked in your entrance examination. So that's the reason why I am revising it quickly. Curer cleft. That means the patient is having spontaneous respiratory efforts. Respiratory efforts. Right? Now, can you see here? Right? Can you see here? This is the baseline and the baseline is elevated. If the baseline is elevated, that means there is a rebreathing of carbon dioxide. Rebreathing of carbon dioxide or inadequate fresh gas flows or exhausted soda lime. Exhausted soda lime. So if the baseline is elevated, then these can be these 3 possibilities. Right? Can you see here? The EtCO2 is like step ladder pattern. Step ladder. Step ladder is seen typically in case of malignant hyperthermia. Right now, can you see this? Can you come to a diagnosis? So this is normal. This is normal. Suddenly it became zero. What does it mean? Suddenly it became zero means there is an accidental extubation. Accidental extubation or circuit disconnection. Circuit disconnection, or very rare possibility is venous air embolism. Suddenly it becomes zero in venous air embolism. But don't tell venous air embolism. Venous air embolism is typically seen in any surgeries above the level of the heart. Okay. Now, can you see this? This is called a leaky sampling line. Leaky. There are two plateau phases. Can you see here? Leaky sampling line. So here is one plateau phase. Here is one plateau phase. So two plateaus. Two plateaus. This is leaky sampling line. Now, can you see there are two peaks here? This is one peak and this is one peak. So this is seen typically in a single lung transplant. Single lung transplant, two peaks in phase 3. Right. And can you see here the inspiratory downstroke portion is slaying. Normally it should come down like this, but there is a slaying. So this is called as incompetent inspiratory valve. Incompetent inspiratory valve. Right. So these are the various images what we use, or what are the equipments, capnographic graphs which I wanted to show you. Then coming to the next one, so oxygen delivery devices. So what is this device? This is called as Venturi mask. Venturi mask. This is a high flow fixed performance devices. Fixed performance devices. Right. So Venturi mask, generally we use fixed performance devices in case of COPD patients, because we want to deliver the fixed concentrations of the oxygen to the patients. Okay. Now, who is she? Yes, she's a very heroine. Not very, she's a heroine. Right. What is there in her nose? So obviously you can tell it, that is nasal prongs. You know, I can also know what is the name of the movie, what is the name of the hero. We all know that. Okay, I don't want to ask this question, but I wanted to ask you one question. What is the flow rates here? Now you tell me what is the flow rate, what she is receiving. Sir, how can I know, sir? Am I not the director of the movie? No. So the flow rates of nasal pranks should be 1 to 6 liters per minute. And with each 1 liter, the oxygen concentration will increase by 4%. 4%. So maximum oxygen that can be delivered is 44%. Sir, how it became 44, sir? I also know maths. So you said 6 liters. 6 4s are 24. Yes. 6 into 4 is equal to 24. But you forgot to add that she is also receiving oxygen from the atmosphere. Right, that is 21%. 24 plus 21, approximately it comes to around 44 to 45%. So this is a low flow. Nasal prongs are the example of low flow variable performance devices. Variable performance devices. Right. In nasal prongs only, there is something called as HFNC, high flow nasal catheter. So what we do in this high flow nasal catheter is we supply heated and humidified oxygen. Especially it was used in case of COVID patients. Heated and humidified devices. So it's like a simple nasal cannula only, but it is connected to a machine which will deliver high flows. And this high flows, we used to use around 45 to 60 liters per minute of high flows, and we started using it in the COVID period. But after that, again, 60 liters per minute is not at all economical. So we stopped using it. This is called as high flow nasal cannula. So don't think nasal cannula, high flow nasal cannula is different. It is like a nasal cannula only. The only difference is in high flows, if you are using high flows, you have to supply heated and humidified oxygen to your airways. Right. Now, who is she? That is not the MCQ. Who is she? This is not also the MCQ. Concentrate on this portion. What is this? What is this? Yes, this is simple oxygen mask. Don't concentrate here. Don't concentrate here. right? Simple oxygen mask. So how much should be the flow rate? The flow rate should be 6 to 10 liters per minute. On lighter note, all the time showing the images without some entertainment, you will also cry. So that's the reason why, some sort of images. So don't take it personally. Just for the sake of entertainment, I kept this image, right? 6 to 10 liters per minute. And how much FiO2 it can be delivered? Oxygen concentration, it increases to around 60 to 65 percentage. Right. Now, what is this one? Sir, this is simple oxygen mask. No, see carefully. So this has got some reservoir bag. This is called as NRBM. What do you mean by NRBM? Non-rebreathing mask. Right? What do you mean by non-rebreathing mask? So you have got, it is a simple oxygen mask only with a reservoir bag. So simple oxygen mask with reservoir bag. With reservoir bag. So this is more efficient than simple oxygen mask. So the flow rate should be around 10 to 15 liter per minute. 10 to 15 liters per minute, and the FiO2 it can increase up to around 80 to 85 percentage. Some books even say 90 percentage also, but let us stick to the 80 to 85 percentage. Okay, so the flow rate should be, when you are inflating it, this bag should be inflated like this. It should not be compressed. If the bag is inflated, then only you can come to know that this is you are giving the adequate flows to this mask. Okay, so this is called as a non-rebreathing mask. Again, concentrate here. Don't look at here. What is she receiving? This is what she receiving. This is called CPAP. CPAP. So just for your sake of entertainment, I kept this picture. Okay, I'll remove it because some people might get hurted. So I'm just removing it. Concentrate on the mask. Don't concentrate on her. So what she is receiving is CPAP. So what is the purpose of the CPAP? Is suppose if you are having any, lung disorders where you want to deliver the fixed concentration, like for suppose a patient is obstructive lung disorder, or if a patient is a known case of COVID, we will have to deliver this fixed oxygen concentration, and we have to supply CPAP, continuous positive airway pressure. So in this, you can supply the airway pressure during inspiration, at the time of inspiration, and at the time of expiration also. That's the reason why it is called CPAP. So it will keep the airways patently open. So one of the contraindication for CPAP is if the patient is unconscious. Patient is unconscious, you cannot use non-invasive ventilation. This is a mode of non-invasive ventilation. Mode of non-invasive ventilation. So obstructive lung disorders, or any patient who is conscious, who is having difficulty in breathing, you will push the air through his or normal passages so that the airways are kept open. Okay, so this is called CPAP mask. Okay, right. Finally, what is this? This is called ambu bag. But what is the question? Ambu bag is not the real name. This is the company name. What is the question is, what is the real name of this device? The real name is called self-inflating manual resuscitators. In the recent NEET-PG, they asked this question. Can you see the valve here? The pressure limiting valve. So when does this valve open? This valve will open at 30 to 40 centimeters of water pressure. Now here you can connect the oxygen source, and it can be delivered through a unidirectional valve to the patients. Right. From here the oxygen will be delivered to the patients. Okay. So this is called self-inflating manual resuscitator, because the first company that has made is Ambu. So people started using this as a Ambu bag only. So if you press this bag, automatically it will self-inflate. Okay, so this is a wonderful device. How much amount of oxygen it can increase? With room air, it will increase up to 21% only. But if you connect it to an oxygen source, it can go and increase up to 100% also, provided you are holding the mask tightly. So this pressure limiting valve opens at 30 to 40 centimeters of water. Okay, so this is very important equipment, ambu bag.